Hi everybody, it's Melissa from AIM and Melanoma coming back to you with Beyond the Clinic, from the clinic to the living room. I just got home from work, so tonight we're going to be talking about adjuvant therapy and really more importantly, or just as equally important, preventing reoccurrence. Reoccurrence seems to be everyone's biggest worry. So you've treated my melanoma, and now what do I do now? And that place of reoccurrence is really a scary place to be. So tonight we're going to talk a little bit about prevention of reoccurrence and very briefly about adjuvant therapy. Primarily I want to explain kind of what it is, what the options are. I was thinking, and this is a job for all of my listeners, I was thinking about covering some adjuvant therapy tonight, but I really have this urge to do a specific Facebook Live on each individual specific type of adjuvant therapy and side effects, how they work. I'll get out my props again. It'll be fun. So if that's something that you would be interested in hearing specifically about the different types of adjuvant therapy in their very own Facebook Live, drop me a comment in the comment section and we can certainly accommodate that. So really, when we're looking at reoccurrence, we're worried about your melanoma coming back. And really that risk of that happening varies greatly between people. And it's based upon really the stage of your melanoma, some of the characteristics including ulceration, mitoses. So there are a lot of things that go into everyone's specific risk of recurrence. Hi, Polly, how are you? So when you look at it, a generalized way to look at risk of recurrence is the deeper or the higher the stage, the greater the risk of recurrence. So reoccurrence is different from having a new primary melanoma too. We have to establish that before we start, because when you're a patient that has had a melanoma, you have a higher than normal or higher than the general population risk of developing a second or a third or a fourth melanoma in your lifetime. And the reason for that is that the same risk factors that caused your first melanoma still exist. So sometimes you can develop multiple primaries at the same time, and that's called a synchronous primary, where you might have a stage 1A on your shoulder and a stage melanoma in situ on your neck, and you might have another stage 3 on your leg. And oftentimes that patients do present that way with multiple primaries at the same time. Each individual melanoma has its own risk of reoccurrence. Part of how we kind of figure what that risk is, and in like stage 1 and stage 2, is primarily based upon the Breslow depth. So we're looking at how deep your melanoma went down into the skin. The deeper it goes, the higher your risk. And it's very simple to figure out. So what you do is you take the Breslow depth, which is on your pathology report, and you multiply that by roughly 10%. And again, this is a rough estimate of risk. And then you look at, are there mitoses? Is there ulceration? Are there TILs? Those are lymphocytes that kind of bring the immune system to your melanoma. The presence of mitoses and ulceration do increase your risk by a little bit. So a very good way to kind of figure that out on your own, and this is something obviously that your oncologist or treating physician can tell you, but a good way to kind of figure that out is look at your Breslow depth, multiply it by 10%. Melanoma in situ really doesn't have a risk of recurrence if it's removed properly, meaning that it has a good margin around it. Stage 1 and stage 2 patients, that's how we figure your risk out. Patients that have a stage 3 melanoma have a little bit more complicated risk profiles because it's based upon the number of lymph nodes, whether there's 1 cell or 50 cells, how many lymph nodes are involved. So that gets a little bit more tricky, but a rough estimate for risk for stage 3 of reoccurrence is around 50-ish%. And the more lymph nodes you have involved and the bulkier those lymph nodes are, that risk does go up. Does it make sense? It's pretty simple. And so the other thing that patients always want to know is, like, how does my risk change over time? And so I always bring out this really handy dandy chart, and patients that see me in clinic know that I like to draw this on like the place where they sit on that paper. I draw it on the back of papers. I draw it on basically anything I can find. But patients that are my patients have seen this chart before. So this is like basically a reverse exponential growth curve where your risk of melanoma is really the highest in the first 2 years. And really even after the first year, your risk drops by itself without doing anything else pretty, substantially. By the third year, that risk is even lower. So you can see even just from the first year to the third year, that risk really drops. By year 4, it's getting smaller. At year 5, that's when your risk is going to be as close to 0 as it probably is ever going to be in your lifetime, and it sort of flattens out. You see this curve kind of, if you could imagine, keeps going. And it never really goes away. So once you've had a melanoma, you always have some risk, even if it's less than 1% of it coming back. And this curve is just a regular, like generalized, graphic to show you, the greatest risk of recurrence is really within the first 2 and 3rd year. The interesting thing is that when you do adjuvant therapy, that risk actually can be significantly decreased. So this is the same curve, but you can see the solid line here is your normal growth curve that we already showed, or risk curve. When you do adjuvant therapy, it really pushes that risk back. And so even just after a year of adjuvant therapy, if you complete a year, it reduces your risk by 50%. So that's huge. That means that this growth curve moves way over here just by doing preventative therapy. So what does that mean? So adjuvant therapy is really prevention. You've been surgically free of disease, either by just wide excision and sentinel node, or by wide excision and further node dissection if that's necessary. Really don't do that as much anymore, but some patients still do have that. So once your surgery is completed, what we're doing is we're trying to really reduce that 50% risk. And so this is really applicable to patients that are stage 3, stage 3 A, B, C, D, E. Adjuvant therapy really for stage 2, B, and C, which is a really high risk. And there's actually a Facebook Live about that specific stage 2 group. They're doing clinical trials because you have a really deep tumor, but your lymph nodes are negative. So there are clinical trials for adjuvant therapy that are testing to see in those higher risk stage 2 patients if it's effective. So for stage 3, so you have lymph nodes involved, adjuvant therapy is something that you're doing to prevent or help reduce your risk of melanoma from recurring. There are multiple options now, thankfully. When I first started practicing with my physician in 2005, there was only one option, and it was something called interferon, and it's actually not really used very much anymore, really, if at all, because there are better options that have less side effects. So essentially, when you're looking at what these adjuvant options are, there's ipilimumab, which is a lot to say. We call that IPI. That's an option. It's given IV. It does reduce your risk of reoccurrence slightly less than some of the others, and it also carries with it a very high risk of developing autoimmune processes. There's another group of adjuvant therapy, which is called PD-1 inhibitors, and they actually target a specific ligand that is present on melanoma cells that help your body recognize it and call it to die. PD-1 actually is programmed cell death ligand 1. So it targets the immune system and tells it, get out of here, it's time to go. And then there is another group, which are called the BRAF inhibitors, and that specific adjuvant therapy is only available to people that have the BRAF mutation. And there's 2 types of mutations of BRAF that actually are indications to use BRAF inhibitors, and that's having the mutation in V600E or V600K. If you don't have those mutations on your tumor, which is something that a pathologist would test, then that type of adjuvant therapy wouldn't work for you at all. Primarily, you see oncologists using the PD-1 inhibitors and BRAF in combination with MEK when you're looking at adjuvant therapy. They're very different. There's no better way to say that. So BRAF MEK is actually a pill or set of pills that you take every day. PD-1 agents are IV. It takes about a half an hour to infuse it. You do it once a month or once every 3 weeks, or every 6 weeks if you get the longer pembrolizumab. But you get them roughly once a month, PD-1 inhibitors. They go in through an IV. It takes about a half an hour to infuse them, whereas BRAF/MEK, again, are oral agents that you take every day. So even just the administration alone, they're very different. They also have different potential side effects. And again, this is where I would really like to spend a good, whole Facebook Live talking about each individual one, what the side effects are, how you prevent them. And so again, if that's something that you would like to hear about, please drop me a note in the comments to say, yes, I'd like to hear that, or no, we don't need to know that. We already know all about it. But one of them, because they're so very different, a lot of times your treating physician will really make that decision based upon your lifestyle, your ability to do oral agents versus IV, obviously if you're BRAF mutated, what your day-to-day, expectations for quality of life and dealing with side effects are. So this is a discussion that actually you should have with your oncologist when making that decision. It's not often something that someone will tell you what to do. There's actually a really great guide on our website, on AIM at Melanoma's website, that will kind of walk you through the things that you need to think about when you're looking at adjuvant therapy. So you can certainly access that through the adjuvant guide on our website. If anybody needs that, I can certainly post that later in the comment section. But those are sort of the things that you look at. Funny enough, the two most commonly used adjuvant treatments, PD-1 inhibitors and BRAF/MEK, actually have very similar risk reductions. So you see about a 50% reduction in risk from both of those groups. So when folks are BRAF mutated and they really have either option of BRAF/MEK or PD-1, there's really not a wrong decision. And so that decision then becomes made based upon the other characteristics of the drugs. So it's really helpful to be able to, have those types of conversations with your patients. So that's a little bit very briefly about, what adjuvant therapy is geared to do. When you look at the earlier stages, stage 1 and stage 2, really the most important thing is following up and making sure that you're doing your routine skin exams and you're doing both at-home skin exams, but also full body skin exams through your providers, through your dermatology office, through your PCP even, through your oncologist. Follow-up is really key, and follow-up, especially during the first 2 years, is very important. The recommendation for most stages is to have a full body skin exam at least every 6 to 12 months, and truly to see someone for a skin exam, like a rough, once over skin exam every 3 months really for the first year. So the best defense against reoccurrence is really a good offense and good follow-up. So that's a really important, aspect of care that I think unfortunately is a little bit overlooked in terms of follow-up. Stage 1 melanomas and early stage 2 really have a risk reduction or a risk of recurrence of about 20% or less. So while you don't have a huge risk of recurrence, that first year is really the most critical in terms of prevention. How do things reoccur? I think that's another question that people have. The vast majority, like 70% of the time, when a melanoma recurs, it happens either somewhere you can feel or see. And so what that means is it'll either be somewhere along where the primary was, either a nodule around the incision site or something that's called in-transit disease, which can be, I think I've used this example before, but if I had a melanoma here, in-transit disease would be developing disease somewhere along your arm here before it got to the lymph nodes that were checked. So in-transit literally means moving. So it's in between your primary and your nodal site that would be most likely. When you have a recurrence for things like that, you can actually do adjuvant therapy with things like TVEC, which are, injectable herpes virus into the actual lesion. We've seen that be extremely helpful for in-transit disease after surgery. We've also seen in the past limb perfusion. Now that carries a very large risk of like morbidity, a lot of cellulitis and drainage issues, a lot of swelling. So limb perfusion isn't used quite as much as it was in the past. But also you can use adjuvant therapy for patients, or neoadjuvant therapy in those cases where you give a little bit of adjuvant treatment, resect the tumors that are left behind, and then give a little more adjuvant therapy. So there's lots of options for in-transit disease. So at the primary site, somewhere in transit, or in a lymph node. And so we tell our patients, especially that have not been diagnosed with lymph node involvement, that about once a month, when you're doing all your other million self-checks that you're supposed to be doing, you should look at your skin. Use a mirror, look to see, does something look different? Are there new things? What does a reoccurrence look like for melanoma? A lot of times it could be a lump under the skin. It could be a blue, purple, red lump on the skin, like a blemish, like a pimple that doesn't come to a head. It can be a black or blue tiny spot. It could be flesh colored. So if there's something that wasn't there before and it doesn't go away, you certainly should have your provider take a look at it. I'm always available to answer questions about that. That's something I do all the time. Patients should also, at that same time when they're looking over all of their skin, we should also look for lymph nodes. And so the best time to do that is when you're soapy. And so obviously you want to check, like back to the original example, if it's on your arm, you want to feel, like I usually tell patients, like start at where your primary is and take your hand and run it along your skin while your hand is soapy and feel for any lumps, and then feel in the lymph nodes for lumps. And essentially it'll feel almost like a marble or a very hard grape under the skin. If it's mushy and squishy, it's probably not something to worry about. But again, also lumps like that don't go away, you should have somebody take a look at, because lymph nodes that are caused by infections or shaving or other inflammatory things should go away after a couple of weeks. So a good rule of thumb is if it doesn't, you should have somebody check it out. I saw a couple of comments. I just want to look really fast. Yeah, Nicole, you should contact me about your side effects. We can certainly talk about some techniques to manage some of those things if you want, about your Taffen-Larn mechanism. You can find my information. Usually someone posts it in the comment section, but if you go to the website, you can fill out a form that I can reach you by email, or if you want to call me, my 1-877 number is also on the website. And then Michael, let's see what you have to say. 3 different spots. Uh-oh, went away. Yeah, so Michael, if you have additional questions about your year of Opdivo, certainly please contact me. I'm happy to answer any questions that you might have about any of that. So I think that we can talk about it offline, because I can't really talk about your personal stuff on Facebook Live, but I'm happy to answer all of those questions. If someone doesn't post, I'll hurry up and go in and post my contact information in the comment section when we're all done, okay? The other thing that I wanted to mention is that really being an active participant in your follow-up is extremely important. So you're your best advocate. You truly, yay, Cher. Thank you for putting my AIM at Melanoma site. So truly, be your best advocate. If there's something that you see that is worrisome, or you don't think it belongs there, or, your skin. So if something is new, you should certainly go get it checked. Please go to your follow-up visits. That's super important in the prevention of reoccurrence, because the sooner we find something like that, the faster we can fix it. Unfortunately, there aren't magical things that you can do to prevent reoccurrence. And so the best defense is truly to go on offense and do your follow-up and make sure you're doing your self-checks at home. Have an open dialogue with your physicians. And if you don't have a good relationship with them, you can also contact us and we can find you someone that you could potentially have a better relationship with. We're always happy to help however we can. I am, just so that you know, taking a the month of December off. I have 2 kid birthdays and Christmas, and so it's a little too hectic at my work between my work life and personal life to have a Facebook Live in December. So, but we took all kinds of information that folks filled out for us here at AIM, and we did something with it. So everybody was kind of craving this emotional, the emotional aspect. We have, me with the medical side, and, folks were really craving some information about the emotional needs of patients and their family members. And so starting next month on December 2nd at 7:00, same time, a Dr. Raymond Liu, who's the director of cancer survivorship at Kaiser Permanente, we're actually starting a new web series with him that is addressing these emotional needs. And the title, this fancy title, where mine is From the Clinic to the Living Room, his is Beyond the Clinic, Living Well with Melanoma. And so his first topic is going to be melanoma, COVID, and the holiday season. And given the nationwide upswing in COVID, this is going to be a really great talk. I registered earlier this morning to watch it. It is a webinar, so you do need to register. But it's something that's going to be totally great. And the plan, his first guest is this woman named Dr. Kylie Nash. She's great. I've kind of been doing some research on the 2 of them. They're fabulous. So I think you're going to really love them. And the plan is to go forward with, there'll be them earlier in the month, and then me at my regular 3rd or 4th week on Wednesday. So you'll have emotional needs at the beginning of the month and medical needs at the end of the month. So we're really trying to cover everyone's needs here. So please tune into that. It's going to be great. You can register on our clinic, and actually I see in the comment section the registration's up there. So click on the link, register. It'll be fantastic. I'm going to come back in January. We're going to talk about nutrition in melanoma, because I know that, in the prior things that I did, everybody really wanted to know about nutrition and what they can do, and the gut microbe. The lecture on the gut microbiome went really well. And so we're going to take it a step further and talk to a nutritionist and kind of see what other things are out there that you can do and get some more specific information. So yeah, I saw lots of my friends. So hi to everyone, and some new faces and names. So it's nice to see you. I hope that you'll join me again back in January. And until then, honestly, check out the new Living Well with Melanoma next month on December 2nd. And please be safe with out there with COVID. Have a wonderful holiday season, hopefully virtually. And we'll get through this. Bye, everyone.